Yes, the question here.
The course of the disease, the length of time from perhaps before even the diagnosis was made, warning signs, that sort of, is there sort of a standard time? Can you say it'll take 10 years, it'll take whatever?
The question was, how long does the course of the disease from the first diagnosis to the end stage of the disease? Well, the challenge with those is that the actual time of diagnosis is so variable, because some people present really late and some people present really early. I think we're looking at, from the nursing home study I talked about, looking at end of life, it had been 6 years since their diagnosis, and they had come into the nursing home. They'd been in the nursing home 18 months, so it was about 7.5 years. Of the people in nursing home with severe dementia, 50% were dead in 18 months. So once it's severe dementia, you're looking at, year and a half. But probably it's anything between 8 to 10 years, but it's very variable. Some people present late, some people present early. It's very variable. Yes, sure. I've got a few here. Yeah.
You said something important. Is there a genetic predictor for Alzheimer's or not?
Sure.
Is there or is there not?
So there is one type of, the question is there genetic predictors for Alzheimer's? There is one type of Alzheimer's that's in young people, and that happens particularly in families, but their onset is in their 50s, and that's about 1% to 2% of Alzheimer's disease, and that's an autosomal dominant gene. In other words, if you get the gene, you're going to get Alzheimer's disease. Not every family member will get it, half of them will get it, or, there are two genes, you've got a 50% chance of getting it, and if you have the gene, you're going to get Alzheimer's disease. But you can test for that gene. Then, if you look at the sporadic Alzheimer's, or what 90% or more have, which is people in their later ages, in their 70s and onwards, although younger and younger, but you will find that there are genes that, when they accumulate, it seems they impact on the disease, but standing alone, they're not strong enough to cause the disease. So that whole pathway from soluble proteins down to plaque deposition, there are multiple genes that drive that pathway. So impairment in genes along the pathway may predispose you, but they're not strong enough to make you absolutely sure have it. Does that make sense?
Yeah, so 70, yes, if there's multiple cases in the family. 50, yes, if you can test for that.
Well, it's not even multiple, because by the time people are 85, 25% of the disease, so it just washes out any family thing. So age is by far the biggest predictor. But so the family history is not that helpful. You've got an increased risk, but it's not like dramatic. So, okay, so I'm going to, yes, what a good question. At age 96, how would you distinguish from normal mental deterioration and dementia? That's such a good question. The purists initially, when we started all this work in dementia, got a lot of press. We called everybody Alzheimer's disease. And then we called everyone Alzheimer's and vascular dementia. And then we were puzzled, because there were people who were getting to 96 and then starting to show changes. And sure enough, when you look at the brains of young people with Alzheimer's disease, they have classic neuropathology of plaques and tangles. And the amount of neuropathology correlates with the amount of dementia. When you look at a 96-year-old brain, the plaques and tangles do not correlate well with the degree of dementia. So you can have lots of them, plaques and tangles, and no dementia. And you can have no plaques and tangles and have a bad dementia. But it's got everything else in. Every kind of damage you can have in the brain is in a 96-year-old brain. It's lived a good life. It's endured the slings and arrows, etc. So I don't know the answer to this. I don't know the answer to this. We know there are 96-year-olds who die with good brains. But I think that the cognitive impairment of the very old is probably going to deserve a category of its own. We're still exploring that.
So, in regards to this question, my question, what are the signs and symptoms of normal mental degeneration?
What are the signs and symptoms of normal degeneration? The purists would say that normal aging is as I've described, that you can remember, you can learn new material, although it's a little harder, you wouldn't forget events, you can plan and organize in your language. That's what the purists would say. However, and then we would also say that once you start to lose those capacities, you'd still call it dementia, But you wouldn't call it secondary to Alzheimer's. You may call it secondary to brain degeneration from being the oldest old. But you would still probably label it dementia if you had those disabilities.
Slow deliberate speech and understanding and putting things together takes a while to answer questions, things like that.
See, dementia just describes a clinical syndrome. You know, it means that you can't put things together quickly, that things do take longer, that it's harder to plan and organize. What are the causes of that is really the discussion. So strictly speaking, there would still be a dementia, but the cause probably is, you know, deterioration of neuronal function, not a specific disease process such as Alzheimer's. Yeah, that's dementia. That we'd call that dementia, strictly speaking. Well, that's a blessing. We call that a blessing. Yeah, it's a tough. Are persons with chronic illness at a increased risk for dementia, such as cancer, diabetes, heart problems, COPD?
Attention visitors, the time is now 8 o'clock. Visiting hours are now over. Thank you and have a great evening.
So definitely chronic illnesses do worsen cognitive function. Kidney disease, hypertension, heart disease, diabetes, probably through mechanisms of vascular damage to the brain, the little tiny strokes I talked about, definitely they coexist. Does the disease itself decrease oxygen supply? It's hard to know because often these chronic diseases are hard to turn around. So whether it's the dementia through the vascular damage, it's hard to know whether it's that or whether it's decreased oxygen. When we give more oxygen, do they function a lot better? Not particularly often. So it's difficult to know. But definitely being unwell worsens function. I mean, I'm really awful when I've got the flu, right? So being unwell is going to worsen anybody's function, even if there's not damage to the nerves in the brain that would correlate with the dementia. And if you've got a tendency to not function that well, you're going to function a whole lot worse when you're unwell. I'm going to keep on going through here. When a party gets violent, should you consider a home? And what percentage of the population have dementia? Well, the first question is one of the hardest. But let me do the easier one. What percentage of the population have dementia? As I say, when at 85, 25% of the population. At 65, I think it's about 5%. I'm so bad with numbers. It's not a good sign. But anyway, it's... I tend to avoid the numbers because it's always like, oh my God, so many numbers, there are going to be so many old people. It's okay, we're going to be all right. We're going to figure it out. So I'm not sure. But when a person gets violent, should you consider a home? This is a really, really tough question. And something I will ask caregivers, if I have any hint of it, is, do you feel safe? Is he ever, or she, I hear they're verbally aggressive, they're restless, they're agitated, they're irritable. How irritable? Do they ever strike out at you? Do you ever feel threatened? Do you ever find you striking out at them because you're so hard and so frustrating? What do you do when you're really frustrated? What does he do when he's really frustrated? So if I get a sense that things are not going well, I'll definitely start asking those questions. And those are the kind of things that people won't report to you because they feel they're telling tales and they're also embarrassed by it. So those things, it takes a couple of visits before you're going to get to the truth around that often. So if a person is violent, the first thing I'm going to try and do is say, are there behaviors that we can modify? Are there circumstances that precipitate the aggression? And try and work with that, as we discussed. Then I'll definitely consider medications that are sedating medications. But if the caregiver feels unsafe, there are a few things I'm going to say. One is you can call the police. They will not come in with guns raised and so on. They will come in. There's a special car that comes for mental health emergencies, and they'll come. So you can call the police, and don't feel you've betrayed somebody if you feel unsafe. You can call an ambulance. They will come, and they'll help you. The other thing is, do you have a way of getting out the house? Have you got a plan? And do you have someone you can call? Sometimes I've given the caregiver a lifeline, so they can press for help if they need it. But you don't want to be that much risk to the caregiver. So what do you do then? Okay, nursing home. Well, honestly, that's as much the caregiver's decision as it is the patient. Most times the person with dementia doesn't want to leave the home. Really, what can the caregiver tolerate and how substantial is the risk? That's the question. How can we put in supports to mitigate the risk? If he's getting agitated in the evenings, can we put in home supports in the evening? If he's bored and restless, can we put him in an adult day program during that time? If there's certain behaviors that are escalating, if he doesn't want to shower every evening and that's the cause, doesn't matter, he can shower once a week and we'll put in a care provider for the shower. So there are ways of working around the circumstance to try and diminish the behavior. Because we all know, and also to reinforce over and over that this behavior is not, it often doesn't reflect who the person was or is, but is the disease. Should you put them in a home? The biggest challenge about placing somebody in a care facility once they've been aggressive is that it's very hard to get them into a care facility because the care facility has really little capacity to deal with really bad aggression. And that's one of the biggest challenges we face. Because you've got one nurse with 20 patients or something, 20 residents. And if one person's violent and the 20 residents are all very vulnerable as well, it's really not manageable. So it's a huge challenge. It's a huge challenge. The worst challenges I've seen is younger, strong men who become very demented and violent, and it's really heartbreaking. So should the care provider put them in a home? If they're unsafe, they feel unsafe, absolutely. But can we work with them to try and decrease the safety of the issues before? That's how I would approach it. About vitamins, like ginkgo biloba, what are they, and are they helpful? The only vitamin that has the evidence that us hardline, straight-laced medical people like me believe in is vitamin D. And I personally don't think any of the other vitamins have really shown in robust studies to decrease this disease, or actually most other diseases. Now, there are many people who will dispute and argue me on that. I'm just giving my opinion. The other in our ginkgo biloba, there was a small study that did show some benefit to ginkgo biloba in the disease, but really not as much as the mainstream medications showed. Live healthy, eat well. I mean, I kind of think we've never been blessed with a better diet in the history of humankind. Do we really need vitamins on top of that? But that's a personal opinion. I shouldn't be. There's no evidence for vitamins. People will talk about lecithin, they'll talk about fish oil. The evidence isn't there in the mainstream medical literature. Does dementia have a gender preference? No gender preference, no race preference, no socioeconomic class, no educational level. Everybody. No preference. I mean, there are more older women than older men, and given that age is such a big risk factor, you tend to see more women with it, but per se, there's not a difference. Am I going too fast through these questions? Am I answering? If you want to follow up, yes. How much vitamin D? Oh, another controversial question. The studies say 1,000, but many people go a lot more than that, and 2,000 is about as high as I would go. I love vitamin D. It's the one thing that reminds us we were once plants. So great. You could get it from the sun. So cool. Yes?
What about coconut oil?
No good evidence for it in the mainstream. Yeah. In the mainstream medical literature, it's not showing. Yeah. It's really tough, these questions about alternate therapies. And I'm not an expert. Yes?
Have you seen examples, perhaps in Canada, where if someone has to be admitted to an acute hospital, where we try to keep the change to a minimum if they're no longer able to live independently, because it seems to be we're just creating havoc by making changes in where they're living.
Let me just understand. So they come from their home, we bring them to hospital, and then put them into the care facility, rather than trying to do it directly from home in a more gentle way? Yeah. Is that basically? It's very challenging. When I first started doing this work, they had wait lists for nursing home. So as soon as somebody showed the least sign of problems, the families would have them on a wait list. Well, the wait lists were insane. They were incredibly long. And then a bed would come up in a facility, and they'd start phoning. Everyone would say, "Oh, no, not yet. I'm still doing fine. Call me back in 6 months." And And then they'd go down the list before they'd find somebody who was ready. And it just was not tenable to do that. So now it's like you don't go on a wait list unless you're quite disabled and you would take the facility within 3 months. That's kind of the push that they're trying to do, which I can understand having been through the chaos of the previous waitlisting system. Having said that, we're pushing people right to the edge of coping at home, right to the edge of coping, rightly or wrongly. If you speak to the people who are living at home, man, they want to be there. They think it's right. It's hair-raising for the family members. Absolutely terrifying. You don't sleep at night. And phoning and driving in from New West to the West End to check in the middle of the night that he hasn't fallen because they just couldn't sleep without checking. Very, very challenging for the family. But we are doing that. We're pushing them to the real last minute. So given that we're pushing them so hard, they're just doing fine, and they don't want to go on a wait list yet, but they get the smallest insult, and the wheels come off. And then they end up in acute care, and then they go to care from there. Oh, it's not a perfect system by any means. I don't know what is. I don't know what is. I think being at home as long as possible, most elderly I speak to, that's their wish. And we're doing that. But it's causing a lot of chaos when that transition time comes. And a lot of acute care admissions, I think, during that transition time. But that is the system. Yes, we cause a lot of chaos, but at the same time, we have given people their wishes to the end. And the mortality in nursing home is quite high. In many ways, it is the hospice, because people are going in so at the end of their disease that many people die in the first few months of being in care. Not because it's a bad place, but because they've stayed out there so long, which is a blessing for many people. But it's hard. It's hard to support it, and it's hard as care providers. One last question I have written here. Remedications, are there negative side effects? I think that's an excellent question. So the cholinesterase inhibitors, that's the Aricept, galantamine, rivastigmine, they can cause upset stomach and some nausea. They can slow the heart rate. And if people have really bad asthma, it can worsen the asthma. Like all medications, there's a list of things that happen to 2%, 3%, 5%. Dizziness, headache, tingling, numbness. Hello?
So some of the medications that are given for geriatric patients may affect other areas of their physical symptoms?
Yes, they may definitely. I don't think there's a medication I know of that doesn't have a side effect profile.
So what you do is you temper the geriatric symptoms with other symptoms the patient may have?
So what I'll do is I'll suggest. No. It's a perfectly good question. What I'll do is I'll discuss the medication, say the limited benefit. I'll say it's
geriatric symptoms.
So I'd say So I'm saying this medication for memory is going to have a modest effect on memory, and it is recommended by the societies. However, there are side effects. The side effects, GI upset, slow heart rate. They may, in some patients, cause more anxiety and agitation in small numbers. That's not what we're seeing mostly. So let's try it. If they want to try it, we try it. If there are any side effects, we can easily back off. I think where the challenge is people who are very demented and can't complain of side effects. Terribly, terribly worrying. Terribly worrying. Go to nursing home, and people who are very impaired on a whole list of medications, and they feel nauseated and weak, well, they're old. Very worrying. Excellent question.
Is there value for the caregiver to be diarising the trajectory of the impairments?
I think, is it helpful to diarise the progression? I don't think it's helpful generally. I think rather you're supporting the strengths and enjoying the strengths rather than looking for the weaknesses. So I do these horrible tests that people have to subtract 7 from 100 and remember 5 words, and they're pretty grueling. And I emphasize to everybody that that's my job, is to expose the gaps. It's your job to cover them up. And that's, otherwise, what is that fair? I think all our families should do that for us, don't you think? So I don't think there's a lot of mileage in that. If you're trying to see whether a medication is effective, you could watch a little more closely. If you think of the target symptoms, so what is the target? Okay, you really like them to not leave the stove on and see whether that behavior changes, or whether they've got out and wandered and got lost, whether that changes. So if you've got a target while you trial the medication, that may be worth doing. But really, to continually expose people, it's going to be excruciating for everybody. And that's one of the things also about memory games. And, it really could be excruciating. So really, I say to people, there are two ways of doing it, and you do both at the same time. On the one hand, you're trying to pull the person back to their prior level of function and hold on to the disappearing function. And on the other side, you're actually moving with them in the journey. And I think you're continually in this little balance between trying to preserve and encourage retention, but you've also got to be able to let go and move down the journey with them. Otherwise, the tension in that is just really difficult for everybody. And I've seen families where that's happened both ways. The one son wanted her to keep playing the violin. The other son was saying, I'm so happy. She was a very intellectual woman. She said, I'm so happy. I've last got somebody to watch Jeopardy with me. So one was pulling her back and the other had now moved down the path. It's an interesting tension, that.
You touched a little bit on it, if the person with dementia says that it's one color and it's not, it's not the arguing and stuff like that, because that seems to be a big, that you want to correct them, but just to let them, but what with my mom, the big problem is that the paranoia with people stealing things, and she hides them, and then it used to be fun to go and find everything, because mom had really good places to hide, and now it's not fun anymore. And when you do find it, it's like, well, who put that there, and who put it there? And I'm really mixed up as to what to do, because her medication is one of the things that she's hiding all the time too.
There's no good answer. These are the painful parts of the disease. These are the painful parts. As I say, there's lots of love and laughter, and there's lots of pain as well, and these are the painful parts. Because for her, she probably feels so betrayed. And at the same time, and how much you correct her. I mean, I would say the least conflict you can get into, as long as she's safe, that's what you should do. And if she says that somebody's stolen, if you can distract her by some other conversation, I know it's not easy. And when somebody's on that, you're going to distract them. And medications aren't going to change things. I would say in that situation, maybe more structure. Maybe more anchors in the day, more people to actually, But again, that's not easy to set up. It's not easy to set up. So some things are kind of insoluble, and you just have to wait until they pass. I would also consider, if she's depressed, if there's a lot of paranoid sense and a lot of restlessness and anxiety and agitation, antidepressants can be extremely effective, better than the sedating meds, if it's the right diagnosis. And they can change things like night and day, if it's the right diagnosis. So I try very readily, I'll try antidepressants. That's something to consider. But those are they are painful parts of this. And that definitely, those kind of experiences are definitely. Got another really interesting question. What about sexual behavior? That's okay. It's okay. So, what about sexual behavior? This is really interesting. It can go many ways. So, among the losses that caregivers and spouses experience is a loss of a partner. And sometimes I'll say to people, it's like he's gone and you haven't had the funeral, because they've disappeared. And one of the huge losses is intimacy. And so for some caregivers, they can maintain sexual intimacy despite the change in the person. For other people, the person is so changed from who they were that they have no longer any interest in intimacy. Ideally, when they're matched, that's fine. When there's mismatch, that's a challenge. So sometimes the person with the disease will want to maintain intimacy, and it's extremely difficult for the caregiver. In Alzheimer's disease, mostly, from what I've seen, people's sexual urges don't escalate, mostly. Mostly it's that loss of initiative, loss of executive function, that shrinking down of outwardness. And that seems to be what happens with patients with Alzheimer's. People with frontotemporal dementias and some patients with Alzheimer's, it can be really difficult. And they can make sexual demands that are impossible for caregivers and become a real bad issue for people. Then even more complex is if the patient has a dementia and the caregiver wants to have intimacy, when is consent no longer valid? And that comes up in residential care. So when can somebody no longer consent? And does consent matter when you've got a 60-year relationship with ongoing intimacy? There's just no hard lines in this whole discussion ever around this disease. In residential care, how things tend to go is if there's a lot of body language, people are watching to see whether people are comfortable with the intimacy that's happening. If there is a partner if it's a marriage partner and one's very demented, they'll watch and see that, again, the body language, and they will not get in the way even though the person's very impaired. Now, if somebody's very impaired and they want to have a relationship with another resident, that becomes a big challenge, and they have to engage family. Everyone's got to sit down and talk about how do we do this honestly, openly, ethically, and not deprive people of intimacy if it's something maybe a joy to them in their dementia. So I've got a hilarious story, but I don't think I can tell it. Shame. It's a big challenge. But mostly people with Alzheimer's are not acting out aggressive sexual behavior. That's not typical of Alzheimer's disease. It's about 8% have sexual-related problems. I mean, this is another thing about educating caregivers. If there is sexual acting out, a lot of it is looking at how the care is provided. So in residential care, people will misinterpret things. So having your back washed or something can be misinterpreted as an invitation to intimacy. And so people have got to be very careful about how care is provided and not to be misinterpreted. Like, it's wonderful to have a hug, right? Totally, and that's fantastic. You'd be blessed with a caregiver who's prepared to give you a good hug. But that, again, you've got to be careful for some people that may be misinterpreted. And then they'll be seen as sexually aggressive, where in fact it was misinterpreting a cue because of their lack of judgment. So there's lots and lots of issues, and again, a lot rests with the care provider with sexual aggression to keep boundaries and so on. But it's a complex issue. And, some care providers will get embarrassed to talk about it or embarrassed that they're still having sexual intimacy. And we're like, it's wonderful. It's wonderful. If you can still have that time together, that's extremely precious. But it's usually much more complicated than that. We talked a bit about violent behavior, which was the next question on here. I don't know if anybody wants any more. So I've tried to get a balance here of the hard stuff and the good stuff. I hope I haven't sounded too rosy about it, because while I'm hearing about the bad stuff, did I talk enough about the bad stuff? Do you feel like I haven't addressed the bad stuff? I didn't want it all to be bad, because anyone who has family members knows there's good stuff too. But there's hard stuff, there's no doubt about it. Any other questions or comments that people might? Yes?
Would you mind briefly just discussing vascular dementia more particularly?
Sure.
It's distinguishable from Alzheimer's
Sure.
in terms of whether exercise and lifestyle would be more important in either prevention or management, and to what degree is it hereditary?
Sure. So the question is to just elaborate on vascular dementia in terms of its similarity or difference to Alzheimer's and prevention. So quite honestly, there's a range of vascular dementias. There's those that are associated with a distinct stroke event, and then the cognitive functions become impaired. And that definitely happens. But the ones that we see more commonly are the multiple small strokes. And classically, they describe vascular dementia as being stepwise in its progression. Honestly, we don't see that. We don't see that. We see a gradual progression. What is it associated with is more motor findings. So people tend to be slower, they tend to have gait abnormalities more early on, may have more slurred speech early on, whereas that's usually a late feature of Alzheimer's disease. In terms of risk reduction, vascular risk reduction, absolutely. There's not a lot of evidence about exercise in Alzheimer's versus vascular. But I can tell you that exercise not only improves your vascular health, so it's not just that you've got lowered your cholesterol, improved your cardiovascular output, it appears to actually release nerve growth factors. So they actually get, for any people who are aware, the hippocampus is the area for memory. It actually can cause hippocampal growth. So it seems like there's something distinct from the cardiovascular fitness that's associated. So I actually don't know whether it's better in vascular or better in Alzheimer's. I think the message is, it's good. It's really good. So that was that. That was the one question. In terms of hereditary, it's got the same sort of vascular disease in general has that same numerous genes that predispose but don't define. So the vascular disease has got numerous of them. So definitely there's more tendency if you've got it in your family, but it's not predictable that you will definitely get it if it was in your family. There are a whole lot of other factors that interact with those genes that predispose you. Is that good? Okay. Any other questions? Seems like time is coming to close up. Well, I really want to thank you for coming, and I hope that's been helpful. It's a conversation that goes on and on and on. Thank you. Don't hesitate to ask for help if you've experienced, if this is a problem in your life for yourselves or your family. And St. Paul's has got an excellent dementia program that's doing a wonderful job. So, thank you.